Thanks, Marty, and thanks everyone thanks for having me do this. I'm honored to help facilitate the conversation. I just wanted to start. I know there's a really important vote that folks have been tracking. The tush push ban has been defeated, so we would but on a serious note, obviously the bill in Congress, it is moving its way through or not, depending on what the vote tally is today. So I thought we'd start there for all three. And just given the challenges that folks are facing nationally and some of the policy changes that could impact healthcare, what role do the three of you see HIEs and data sharing in particular playing in this evolving landscape?
I kick things off. Do you want me to?
Sure.
Can everyone hear me? Okay, great. Yeah, just big picture. This is really a timely meeting because this is happening in real time as far as the budget reconciliation process. They're meeting now in the House Rules Committee to sort of hash out, the scope of the legislation, the scope of the Medicaid financing reductions, and other kind of contentious issues in real time. They're trying to meet Speaker Johnson self-imposed deadline of before Memorial Day to have this passed by the House. And so, uncertain at this point. I think the big word is sort of discussions are fluid and a lot of uncertainty. But make no mistake is that Medicaid financing reductions are very much, at substantial risk here as part of this package. And so the number has sort of evolved. At first it was $880 billion. Now it's about north of $700 billion. They're sort of in two buckets. There's about a dozen or so policies that are included in this reconciliation package currently. But they're kind of two broad buckets. One is really a set of policies that are really intentionally designed to make it more difficult for Medicaid beneficiaries to get Medicaid coverage and retain Medicaid coverage, whether it's unwinding previous regulations from the Biden administration that was really focused on, continuous coverage, whether it's requiring states to do more frequent eligibility checks, requiring states to set up work requirements that are very complicated to administer. There was efforts to do this in the previous Trump administration with very mixed success. So that's sort of like one bucket of issues. The other bucket is really an effort to shift costs to states, reduce federal spending, but shifting those costs to states, particularly how states finance their non-federal share of Medicaid funding. A lot of the policies are really aimed at how states use provider taxes to kind of finance their non-federal share. There's also threats there on the other side, on the regulatory side as well. So there's some interplay between what's happening in Congress versus what the administration is trying to accomplish via regulation. So those are two main ways. There's obviously we'll talk about these policies in more detail. Big picture, the Congressional Budget Office, which is sort of like the nonpartisan, scorekeeper in Congress, they've estimated that about 9 million people would lose their health insurance coverage as a result of just the Medicaid funding reductions alone. When you take into account some policies, both in the Energy and Commerce Committee and Ways and Means, that really look to sort of limit eligibility in the ACA exchange, and then plus the non-action on sort of the enhanced advanced premium tax credits, you're looking at most experts like 13.7 million. So really substantial. $715 billion of Medicaid cuts, almost 13.7 million people losing their health insurance coverage over the next 10 years. One thing I would just underscore is that this process is happening right now, and it's not a foregone conclusion. This number can change. It could take a lot of different twists and turns, even if they were able to pass this legislation this week, which I'm extremely skeptical they would be able to reach consensus by this week. Eventually, if the House does pass something, then it goes to the United States Senate, where inevitably, there'll be changes and modifications as well. So everything is moving really fast at the federal level, but there's still a lot of moving parts and still really an opportunity to kind of shape, what's happening. Now, how does it relate to sort of health information exchange. I think it's really, you're talking about kind of Medicaid reductions of this magnitude. There's no sort of efficiency or program integrity that is going to make the program work better. It's just really about when you're talking about cuts of this magnitude, it's going to have real world implications on Medicaid beneficiaries, on state budgets, on providers that serve vulnerable populations, and state economies and local economies, just given the outsize portion of Medicaid that is part of state budgets, that this is going to have, real world implications if sort of the funding magnitudes of this kind are going forward. For health information exchange, sort of more of an indirect effect, but certainly all the partner organizations that are part of this, this is, real world implications here. And you're thinking about particularly providers that serve vulnerable populations, underserved areas, rural areas. This is really, pretty existential threat to hospital finances when you consider all the policies in combination. And when if a hospital, closes, that just doesn't impact Medicaid beneficiaries. It impacts, everyone who receives care at that hospital or facility. So just sort of like big picture. And again, this can change. These numbers have fluctuated over the course of this sort of debate. And, they could go up, they can go down. And so nothing is sort of set in stone, but I just wanted to kind of set the table, sort of where we are now, what sort of the implications are, and happy to turn it over to my colleagues here. Thanks.
Hi, I'm David Horrocks with the New York eHealth Collaborative. And I don't have any special insights into the big picture federal policies, but I would say that for public health agencies, even before anything happens on the Medicaid program, the era of austerity has already arrived for many of them, as the COVID funding has been wound down, and we should just expect that, I guess, the further we get away from the pandemic, the less willing we all are to fund those activities. And so I think as health information exchanges, when they work, most effectively, I believe they can function as a partner to the jurisdiction where they operate. They can essentially become a utility, a health data utility for the jurisdiction. And that's going to let our public health agencies, do certain things that, perhaps they could partner with their HIE, their health data utility, to operate registries, or to do some of their data analytics, or to de-silo. We're really good at siloing our data, to de-silo the data that we are already collecting. So I think that there are some really interesting opportunities for efficiency just in how we do our public health work. So I point to that first. A health data utility should combine data to enhance data. And I think that it's more powerful than most of us have realized or have taken advantage of. And then health information exchanges, as they do that, they are a sort of close cousin of other health information organizations, of the all-parent claims databases, of other discharge summary data sources, and I think they can provide more real-time information to enhance those sorts of insights. So the old adage, you can't manage what you can't measure. And with the changes that inevitably will come with reductions in coverage or changes to these programs' eligibility, I see these health data utilities as playing a quite helpful role in helping our policymakers understand and respond.
And my name is David Wade. I'm with the Governor's Office of Transformation and Opportunity. And I think from our administration's perspective, we're obviously concerned about what's going on. We're in very much preparation mode, trying to monitor it and be ready for it. As it relates to this space of health information exchange. I think the good news from where we sit is that the exchange of health information has always been pretty bipartisan, and seems like the current administration is going to continue that going forward. They've sent some signals that they're open to making some changes to TFSCA. I'm not even going to begin to try to unpack that, but that's the mechanism by which more of these networks are talking to each other across state lines. I think that's a good thing. So we're focusing on that.
Thanks. David Wade, we'll stick with you. Obviously, the governor has made transformation and innovation a big part of his agenda. So generally, speaking, sort of wondering how can we leverage the amazing assets that Pennsylvania has? There's obviously everybody here represents an amazing asset, but given the climate, given the importance of data sharing and HIEs and how that all connects, what are you looking to? What's the government looking to achieve on that space?
So I think we're looking at these amazing assets and the exchange of information across them as a real driver of economic opportunity and economic growth. The governor's economic development strategy called out life sciences as a place where we should win, and we are winning in many ways. We're fourth in the country in NIH grants. We are seventh in clinical trials. That brings in about $1 billion every year in Pennsylvania, which is great. And we want to double down on that. And so the governor's put forward an innovation fund in his current budget that would invest $50 million, $30 million earmarked for life sciences, really focused on trying to build out and invest in this growth potential. And a lot of that investment is targeted at exchanging information better, getting institutions to work more effectively, to speed the path to drug development, and making Pennsylvania and the assets that we have a real draw to develop and keep companies here in Pennsylvania.
Thank you, David. I'll kick it back over to second David. So we're talking about like all of these uncertainties and obviously HSX has done a great job in all the HIEs and sharing data and building a footprint. Sort of what have you learned in New York? And, as we prepare for changes that may occur at the federal level that will impact, states, like how's New York approaching that problem? Or the lessons that we can learn as we move forward with this work in the Commonwealth?
Sure. Well, New York and Pennsylvania have significant similarities in how HIE has grown in the states. Both as large states have found themselves with strong regional HIEs that generally corresponded to the metro areas. And these HIEs provide really strong services within a particular jurisdiction, a particular city maybe, but some are stronger than others, and they're not as statewide. So our priorities at New York, we have 6 regional HIEs, are to improve our statewide-ness, if you will, to get more efficient at the basic exchange of data, and third, to do that without breaking what works in the communities, supporting the communities where they rely on their HIE partner. And as we do that, we see the work of the national networks as very positive, and we are leaning in on that as we can, as the extent we can get some of our privacy policy aligned with national exchange. And eventually we want to be more complementary to those national exchange methods. So, I'd say a big strategy right now within that framework, or a big initiative right now, is we are taking our strongest regional HIEs and saying, we need you to do this across the whole state. And that's how we'll get that statewide-ness. We're not, and my organization sits sort of astride those 6. Instead of building it inside our shop, we're doing contracts with our strongest HIEs, and they are building things that go across the entire state. So important strategy for us.
And given that, just if we could stick on funding for a second, David, how, obviously it's a lot different here in the Commonwealth. This is a member-driven organization that helps stand up, as was mentioned, HSX. What kind of funding models have you looked at? I know there's a state appropriation, but are there other funding models that you're looking at as we try to enhance what we're doing in uncertain policymaking situations?
Yeah, the HIEs in New York are funded through a combination of the state's own contributions and contributions of the participants. The state's contributions are we have a covered lives tax that funds several different initiatives, including our HIEs, and then we have Medicaid matching dollars that provide a lot of help for us as we try to build out the services of the HIE. So we've really tried to focus the public dollars on things that support our Medicaid program and other public health purposes, and try to have HIEs that have access to the data and the capacity to do support for other shared savings programs outside of the Medicaid and Medicare program.
That's a great thing. It seems like some of the themes here are leveraging assets that we have, and then also partnerships that break down silos, which I think this room is a great example of. Some of the other work that's being driven is obviously an 1115 waiver that has been supported and submitted by the administration, as well as PA Navigate. So in this world where the department has to focus on the vote that I wasn't joking about on the front end, and trying to be creative at the same time, are there different ways in which HIEs and data in particular can, and this is for all three, to jump in where that can be supportive of a broader agenda?
I'll hold the mic just for a second to talk about the 1115 waiver in New York State. And under this, there's a number of parts to the waiver, but one part is to identify unmet social needs for Medicaid beneficiaries who have the most intense care needs, and to get them connected with community-based services that we believe will improve what are essentially health-related social needs. And that requires a bunch of new coordination with organizations that haven't typically been in a medical referral loop. And our HIE infrastructure is proving really helpful for that. In fact, we couldn't operate the program without the HIE. So I think it's an example of the HIE supporting the aims of the Medicaid program and the 1115 waiver.
Yeah, I could talk about kind of Section 1115 waivers more broadly. I think, with this new administration comes new policy priorities. And so I think what you're seeing is sort of early signals that the Trump 2.0 administration is going to take a very different sort of perspective on sort of the flexibility for states to kind of address these health-related social needs than under the previous administration. There's two sort of major actions that I think are just worth noting. One is in March, the new sort of Center for Medicaid and CHIP director sent out like a memo or a bulletin early March that basically said, we are rescinding previous guidance from the administration that was really encouraging states to really invest in health-related social needs using their Medicaid programs. So there's like two bulletins from 2022 and 2023, and sort of right out of the gate, they said that these were rescinded. They did note that that specific guidance didn't impact any current waivers, but was sending sort of a strong signal that they were going to take a different sort of approach to this. And then in April, they sent additional guidance around this that really was a little more concrete. And again, if a waiver currently exists, it's not impacted by this, but does have implications for both waivers that are new waivers as well as waivers that will be up for renewal. And so a lot of that has to do with SDOH. We know these interventions are highly effective and work and keep people out of the emergency room and keep people compliant with their treatment and kind of address whole person care. And so the implications are this sort of uncertainty around the ability of states to continue to draw down federal match for these incentives. So that doesn't mean that these programs won't necessarily continue. States could still use it with their own state funding, but it's likely to have sort of far-reaching implications as far as the scope of those interventions and sort of the federal support available.
As we're rounding into budget season in Harrisburg, I'd be remiss if I missed this opportunity. And so I just wanted to sort of underscore, to Mike's question about where funding is coming from. The Governor's Innovation Fund is coming out of Department of Community and Economic Development. So this is money that is not typically gone into this sector. That is going to, assuming we get it with help from folks here, it's going to certainly have an economic impact, but it's also going to help improve health. It's going to get cures developed faster. It is going to ensure that diverse populations are included in these studies. And so there's sort of three life sciences components. We've got our executive talent initiative. We've got clinical trials network initiative, where we're trying to do exactly what they're trying to do in New York and connect up different institutions and different HIEs across the state. And then a life science challenge grant that's going to really go towards infrastructure for the industry. But I think it's a situation where we're trying to certainly leverage dollars in the economic development realm to also impact health.
So thank you for that. And sort of take the challenge from a more macro perspective and bring it home more micro, and that's closure. So obviously that's a difficult situation. There are a lot of hospitals that are facing financial challenges. So as you see some impacts, and obviously the governor's office is trying to fill in gaps, just wonder where can HSX, HIEs sort of step in and help in situations that are extremely unfortunate in terms of network adequacy and quality of care.
I think that this situation proves out very much the value and importance of HSX and the work that you all are doing. Crozier actually was continuing to feed data through HSX about admissions, transfers, all that. We have clinical records from those patients that are in Commonwealth HIE. So that's good. The system works, but it only works when your institutions are working with their HIE very actively. It's incredibly important, especially in any of the systems or hospitals where you're seeing trouble, to go ahead and really be aggressive in making sure that folks are leveraging the HIEs.
Well, I don't know the specifics as well as certainly Marty will be able to figure out what HSX can do. I guess one of my daughters was born at Crozier Chester, so I'll speculate here for a minute on what HSX can do. Probably HSX has patient panels from the primary care providers in the region of Crozier Chester, and you can combine those. When we talk about combining data to enhance data, you can combine those patient panels, sort of a form of attribution of a patient to PCP. You can combine that with discharge data from Crozier Chester to know, all right, where is the impact and what practices were really referring there, and you could combine that data with other sources of information, potentially the emergency department or freestanding ED or urgent care data. Urgent care data is hard to get. I don't know if you've got that, Marty, but to understand where the impact is and to try to intervene, because you're clearly going to have gaps in coverage here. So just a few thoughts.
Yeah, I agree with my speakers here on sort of the crucial role here that the health data exchange can play in sort of continuity filling gaps. I think that's all, really important and really critical. I do think it does get to the larger issue, just sort of when we're talking, going back down to the federal level, when we're talking about like spending reductions of this magnitude, just the real world impact that'll have on, providers that serve vulnerable populations. And, in Washington, D.C., the hospital associations have been really doing a great job just bringing awareness of sort of those real world implications for providers in rural areas and underserved areas. When you do all these policies in sort of combination in a stressed kind of fiscal environment, that this could really lead to major access issues. And it's not just for Medicaid beneficiaries. When these facilities potentially facilities close, it really impacts the entire community. It impacts not only the health of the community, but the economic viability of the community as well. So not to be sort of all gloom and doom about it, and then there is still opportunity to kind of shape this too. I would just underscore that this is moving really fast, but it's still early in the process as things are moving so fast, but also things could change direction really quickly. That's just the way these things go. And so once at some point people think like this is inevitable, what are we going to do? Let's just throw up our hands, and then there's a turning point and something happens. So none of these like numbers we're talking about are set in stone. And there's really opportunity for those who are kind of concerned about real world impacts in this space to really make your voice heard and have an impact.
Just one more thought. I don't know if you're using your Medicaid claims data effectively for these purposes, but boy, if you had the Medicaid claims and even Medicare claims into certain shared savings, you derive chronic condition flags out of that. The data I described earlier, you marry that to the chronic condition flags. And now you're able to go to practices and say, in your case, here are the 30 most at-risk people who've been using this hospital, who have asthma, or whatever the thing that puts them at risk, and how can you're so much closer to an intervention that can make an impact at that point.
Well, thanks to the three of you. I'm going to turn it back over to
Yeah,
you, Mark.
so we have time for a few questions, so we'll ask the mic.
My question then, so these Medicaid costs, the way I'm reading it, are due to go into effect in 2029. So does that mean that it's more symbolic today and the real hurt will happen 4 years from now?
Yeah, it's a good question. I think a lot of these provisions are sort of they're interrelated. You're correct that this sort of, which we talk about, there's sort of a national work requirement that would not go into effect until 2029. All the other provisions would go into effect in 26 or 27. So I think with the work requirement issue, like why are they delaying until 2029? I think it's sort of, two answers to that. One is that the experience of states in trying to establish work requirements in the first Trump administration was, very mixed record. And one state that went forward to do it was Arkansas, and the experience led 30,000 people to lose their Medicaid coverage in like 4 months, and then it was eventually struck down. And it's just the enormous complexity of making a work requirement and how to make it make sure that eligible people get their coverage and maintain that coverage, and the enormous cost to states in implementing that program. So the provision does have $100 million for implementation costs for states. So I think it's sort of two things are sort of pushing the thing. It's the practical impact of like what an extraordinary lift this would be for states to actually establish a working program. And then second is sort of to push the costs out and kind of push that out there. But that specific provision, even though with the delayed implementation dates, was reduced federal spending by $290 billion over the 10-year period. Actually, most of the savings, a plurality of the Medicaid savings comes from that. And according to like experts like Congressional Budget Office and others who have looked at this, it's not because people are who otherwise, who are, would otherwise be eligible for Medicaid or getting employment and getting private insurance. It's that otherwise people who are eligible for the program under the current rules are not getting their Medicaid coverage because of paperwork and systems issues. So that's really where the savings are coming from. So it's extraordinarily complicated. Again, a lot of issues for states implementing that. And so to do a nationwide requirement, they're like, well, let's just push this off until 2029.
Let's give this panel a hand. Thank you.